discussions towards the end. So next we have Dr. Reesha, who's a cataract surgeon, senior consultant, medical retina and UV at Little Flower Hospital, Angamali, and she'll talk to us on common inflammatory disorders of the posterior segment. Over to you, Dr. Reesha.
Thank you, Dr. Shishir. Before I start my talk on inflammations of posterior segment, I'll show you two slides. See, this young girl presented with severe occlusive vasculitis bilateral 1 week after a dengue fever attack. So we were like, dengue usually doesn't cause this much of occlusive vasculitis. So we were searching for a rheumatology cause in this girl. And after 2 weeks, this was the picture. Both eyes, she developed vitreous hemorrhage. She had undergone immediate VR surgery. Her all rheumatology workup came to be negative. That was a case of post-dengue occlusive vasculitis. So timely diagnosis is very important. So can we treat all posterior segment inflammations with systemic steroids? No, all these posterior segment, posterior uveitis looks very much similar, but all these have different clinical diagnosis, and most of them are infectious also. So I'll give you 10 practical tips for the management of posterior segment inflammation. The first and most important tip is a good history taking. This 23-year-old 7-month pregnant lady presented with choroiditis with inflammation. She gave a history of pulmonary TB for her mother 1 year before, and also for her sister treated for 6 months. So that was a case of choroiditis due to tuberculosis. Her manto was high, ESR was also elevated. She was treated with ATT and lesion resolved completely. Another young engineering student presented with an intermediate uveitis like picture. So after all evaluation, all investigations came to be negative. So we started him on systemic steroids. See, after 1 week, the vitritis was worsening. So again and again we were asking for anything we were missing in the diagnosis. So he gave a history of IV drug abuse. So that was a case of endogenous endophthalmitis. And yet another forest officer presented with this lesion in one eye, and we were keep on evaluating and couldn't find out any positive history, any positive investigations. Then patient was asking me, doctor, is it related to any of my dushilams? So immediately I sent the investigations, HIV, VDRL, TPH, and VDRL and TPH came to be positive. So that was a case of syphilis. And after starting on CP and steroids, the lesion resolved completely, and we could regain the vision. And the second tip is good physical, head to foot physical examination. See, this patient presented with a bilateral hypopyon uveitis with vitritis and vasculitis. And on evaluation, he had mouth ulcers, so it's a case of Behçet. Next, bilateral posterior uveitis with disc leak and pinpoint leaks in FFA. Patient may or may not have these systemic findings like alopecia and vitiligo in a case of VKH syndrome. See this again, a young lady presented with bilateral occlusive vasculitis, and patient had this malar rash. So it's a case of SLE retinopathy. And the third tip is good ocular examination. See, this patient was treated as intermediate uveitis initially. See, on indirect ophthalmoscopy initially, an active toxos lesion is there. So it's a case of toxo-uveitis. Again, examination of the other eye is also very important. This patient presented with granulomatous uveitis, and fluid detachments. And the other eye, old history of trauma, thysical eye. So that was a case of sympathetic ophthalmia. And the fourth tip is always exclude an infectious cause. See, these are all infectious examples of infectious uveitis. First one is ARN, which needs immediate treatment, and second is toxoretinochoroiditis, and third one was DUSN. And of course, tuberculosis, always rule out tuberculosis in all uveitis because it can have protein manifestations. And whenever you are not able to find out anything underneath because of severe vitritis, go for PCR so that you won't miss any viral retinitis. And the most important thing is, if the inflammation is not responding as you expect to your steroids or other immunomodulatory therapy, again ensure that an infectious cause is not missed. And do not miss an active inflammation. In this case, patient BKH patient has some bilateral pan uveitis. FFA shows disc leak and pinpoint leaks, and EDI OCT helps in these conditions. Macula choroidal thickness reduces as the lesion heals. And this picture shows a healed serpiginous lesion, but fundus autofluorescence shows there is still active lesion is there and needs more treatment. And do not forget about masquerades with obtaining a biopsy. This child presented with hypopyon uveitis not responding to topical steroids, and AC tabs showed retinoblastoma cells. Again, these two cases mimic very much like posterior scleritis, but look carefully, there is no signs of much inflammation. And first picture was CA breast with choroidal metastasis, and the second picture, patient had CA lung with a choroidal lesion. And if indicated, do not hesitate to start steroid sparing agents. Even though steroids are the mainstay of treatment, if patient needs long-term immunosuppression after a high-dose corticosteroid pulse therapy, you may have to go for immunosuppressive agents or biologicals, and consider sustained release steroids like Ozurdex if patient has CME complicated to intermediate or posterior uveitis. And think about other non-uveitic conditions also. Like this patient was treated as toxo-uveitis. She was already on Bactrim DS and steroids, but no improvement. CFFA shows this pinpoint leaks. This was a case of CSR with fibrin. So immediately we stopped steroids and gave laser. And do not forget about complications like toxo scar can have associated CNVM, and OCT could pick up. And always discuss with your friends. And these are the 10 commandments: proper history taking, physical examination, complete ocular examination, exclude infectious cause, do not miss active inflammation, do not forget about masquerades. If indicated, do not hesitate to start steroid sparing agents, consider sustained release steroids, think about non-uveitic conditions, and discuss with your friends. Thank you.
Thank you, Dr. Reesha, for that superb talk encompassing all the posterior